All right, so we move on to the second presentation this morning. I'd like to introduce Dr. Paul Keown. He's a professor of medicine, director of immune sciences, lead of the Precision Medicine and Transplantation Research Excellence Cluster. And Dr. James Land is assistant professor at UBC Department of Pathology and Laboratory Medicine, Division of Nephrology, among other things, and director of the HLA lab at Vancouver. So they're going to talk to us today about an action plan for epitope matching in kidney transplantation. Take it away.
Thank you, Sean. Hi, everyone. Good morning. It's a real pleasure to be here to represent the immunology team. We're so excited that you're going to get two for the price of one in this lecture. Before I launch into the talk, I see a lot of our technologists here today, and I just want to highlight that immunology, we seem to be always working in the background. Our lab is located right around the corner, but I can assure you the technologists we have are highly dedicated. I've worked in many different places, and the dedication, the commitment to transplant is unparalleled here. And they're super friendly, so if you ever want to visit our lab, just come around to us and be happy to chat with you. So today, Dr. Keown and I, we will take you on a journey through what the barriers are in transplantation and how can we overcome them. Where do we stand today? Where are we going in the future? We will touch briefly about histocompatibility antigens. We will talk about epitopes, how we detect them, how we measure them and apply them in transplantation, and the opportunity for precision medicine and tolerance in the future. I begin every talk with this slide here, just to remind ourselves, why do we even do transplant in the first place? What is our mission? Kidney disease affects 1 in 10 Canadians, and there's about 50,000 Canadians with kidney disease, with end-stage kidney disease. The mortality for someone on dialysis is over 50%. People talk about cancer mortality all the time, but it's sobering to know that patients with kidney disease, when they're on dialysis, half of them will be gone in 5 years. So it's a race against time for us to find the organ to get them off dialysis. It's not just about patient survival, it's a huge economic cost for the system as well. It's costing the Canadian system over $2 billion a year. And unique to transplant, it offers mortality benefits and quality of life. So you guys will notice that we begin to transplant patients who are way older. This year, we transplant patients who are 79, 80 years old for kidney transplant. And when we assess them for transplant, we tell them that you're not going to live longer with a kidney transplant. So why do we even bother doing it? It's because nobody wants to die on dialysis. You know, imagine fast forward to your late 70s or 80s. You know, when you come to the end of your life, who wants to spend time on dialysis? Nobody does. And that's what we're offering them, is the quality of life, freedom from dialysis. Transplant saves the system $250,000 over 5 years. You know, we hear about economic constraints, resources, and all these things. From my perspective, they don't matter to us because we're saving the system money. And very few things in healthcare can do that. And I think everybody should be very proud of the last statistic. This is unique to BC. Over half of patients with kidney failure in BC are now treated with a kidney transplant. The national average is 43%. So more than half of the patients with end-stage kidney disease in our province, now the treatment is transplantation. You know, so we're not some therapy that's minor. Like we are the majority now. This is the dominant treatment of choice. You know, so whenever we're tired, you know, and that happens to me all the time, I'm talking to Dave, you know, talking to our technologists, it's easy to find ways not to do transplant. You know, it's too costly, post-ischemic time is too long, that donor is too old. There's a million reasons why we don't pursue kidneys, but we always have to come back and say, what are we doing here? We have to believe that these organs are the right thing for our patients, and that's why we do them. Dr. Harriman talked about all the work that goes into transplantation, and it's true. But if we take a very high-level overview, what happens to these kidneys once they're implanted into the patient? What you see on the left-hand side, all transplants, If you look at the different lines, they indicate, these are BC data, by the way, from 1995 to 2020. So what you're seeing here is that there's an incremental benefit over the different era. So at the very bottom, back in the early days in 1990s, transplant outcomes over 10 years, half of them will have failed over 10 years. But if you look at where we stand today in the red, you can see it seems to be followed in the path that about 25% of kidneys fail over 10 years. So we're doing much better. So we should not be complacent though. If you look at the era of 2008 in pink over the red, what that shows is that we haven't made any improvements. We seem to have plateaued in terms of our outcomes. And so you can, patients ask me this all the time. If I get a kidney transplant, how long is my kidney going to function for? And I'll say statistically over 10 years, 25% of kidneys will stop to function. Either you go back on dialysis or you need another kidney transplant. I think we can all agree that's not optimal. So why do kidneys fail in the long term? That was a dominant question about 2010. And there were several studies, this is one of which that came out, that show if you biopsy these kidneys and understand why they fail, that half of them are lost due to rejection. So we do all this work, we have the gift of life from donors, we put it into the patient, and then they're on immunosuppression. But over time, the immune system does begin to attack the organ, and half of them are lost due to rejection. So basically, here comes to the primary problem in kidney transplant where we stand today, is that the way we do business, the way we give immunosuppression, the way we do transplant, the safety zone for the patient is fairly narrow. Now, when we give immunosuppression, there are some patients that will have rejection because the intensity of immunosuppression is not enough. However, if we give too much, they go to the other side on the right. They start to get a side effect of immunosuppressant, infection, cancer, toxicities. And so they kind of go back and forth. And that's why if you look at global outcomes in Canada, every center has pretty much the same outcome. What I show the statistics, they're not unique to BC, that all these centers in Canada have pretty much the same. So how can we move the needle on this? And that's the question that our group asked. And we said that, well, maybe the way is we need to completely revolutionize how we do transplant so we can overcome this problem of rejection. And Dr. Keown, he's very shy to put up his picture, but I did it anyways. He's a fierce leader who helped us secure this Genome Canada grant about 4 years ago, which allow us to anchor ourselves to be the site in North America to study this problem and to come up with a paradigm shift way to allocate and to treat our patients so we can move the needle on transplant outcomes. The first step that we said, well, how did our forefathers do transplant? Can we replicate that? Because back in the days, what you're seeing on the left are the Herrick twins. They were the first successful human transplant for kidneys. And the reason it was successful because they had no immunosuppression back in the days was that they were identical twins. But that won't get you very far if all you do is identical twin transplants. So we begin to do disparate HLA transplants. And then you see the numbers on the right is that for every mismatch in these human leukocyte antigen genes, these are the defining genes for immunity. If there's a difference between the patient and the donor, and what you see from the top 0 mismatch to more mismatched at the bottom 6 mismatches, you can see a difference in the outcomes. And what that also shows is that while we have immunosuppression, they're not that good, so they work to some extent, but you can still see a difference in outcomes even when patients take their drugs. But is there a way to do this though, that we can fool the immune system so that we don't have to worry about this disparity? So what you're seeing there in the cartoon on the left upper hand, antibodies, they attack the organ, but they don't bind to the entire HLA molecule. They bind to discrete amino acid sequence on the HLA molecule. So what you see on the ribbon diagram on the right is that you can see that entire molecule has those red amino acids. They're the targets of which you can form an immune response against. So how can we fool the immune system then? If we have a patient, as you see on the bottom, a patient who has a molecule called B7, and then they have three potential donors. Donor number one carried the molecule B8 and then B35, and another donor is B44. And you ask me who is a better donor, I will say that they all seem the same to me. Every donor has one mismatch with a patient. But is that actually the reality? And I would say no, because if you look at the actual amino acid sequence, so what you're seeing on the right, the entire, all these alphabets for the recipient line up against the donor. And when you see just like a straight line, it means they're the same. And when there's a difference in amino acid, it's indicated by the change in amino acid. You can see donor number one only has one amino acid difference compared to donor number three, who has many. So from the immune system perspective, these three donors, donor number one is infinitely better than the last person, just because there are less targets that are different between the donor and the patient. So can we leverage that to do precision medicine? And for a very long time, we kind of think about precision medicine as a buzzword, something in the future, we're never really going to do it. But we're at a point that we can do this very soon, in the next quarter in BC. And this study was presented last week simultaneously at the American Society of Transplantation and the Canadian Society of Transplantation. And I just want to acknowledge Jenny Tran and Eugene Choi, who are members in our lab, who did a lot of the work, which I'll show you here. And to show one way that we can leverage difference between the donor and the patient to guide how do we give immunosuppressants. What we did is we took over 1,000 patients transplanted in BC over the past 4 years, from 2018 to 2021. And then we calculated the disparity in these amino acids between patients and the donors. And we characterize them into high mismatch or low mismatch. So the idea here is that if the donors just happen to be by happenstance well matched to the patient, then they're going to have a less risk of rejection. And is that true or not? The first thing to note is that we give two kinds of induction treatment. These are immunosuppressive medications that we give to patients at a time of transplant. And there's a high intensity called ATG, and there's a low intensity called basiliximab. If you work in a post-transplant clinic, you will know that this is one of the critical points we always chart in patients, because high intensity immunosuppression ATG, it lowers the risk of rejection, but there's a price to pay for it. They have a higher risk for cancer, they have a higher risk for infections. The trade-off for basiliximab, which is the weaker agent, is that they have a higher risk of rejection, but they have a lower risk of infection. So for a very long time, we have really no good way to pick who should get ATG or the more intense regimen or basiliximab. And so what you're seeing here is that if you take everybody over the past 2 years, you look at their rate of rejection, those ones that receive ATG, they're about 4 or 5% risk of rejection. But that risk is doubled when you get basiliximab. However, if we re-stratify patients by their epitope mismatch into higher or low, what you see on the top, these are the low mismatch patients. You can see the risk of rejection is much lower than patients who are high mismatch. If you then stratify this by the induction that they get, and on the very far right, you see basiliximab, you can see a very big difference. Patients who are low mismatch, they seem to do very well in terms of risk of rejection, but when they get high mismatch, then they have a much higher risk of rejection. That gap between the two is narrow when they get ATG. So what that means though is that at the time for transplant, if we had this information, then we have a lever to push. If I know that this organ is highly mismatched for my patient, I'm going to give them ATG. That just makes sense. However, if they are well matched, we can spare them the toxicity of the medication. They can go down the path of basiliximab. When we did a multivariable model accounting for all the other factors that can account for rejection, we still find that mismatch between patient and donor came out to be very crucial as well too, as you see. A 3-4-fold higher risk for rejection when they have a high mismatch. And then we put all this data together, combining mismatch and induction. So now we have a way to label patients at the time of transplantation, that if they get low mismatch, as you see in green, and they get ATG, virtually they're not going to reject, 3% risk. Then we have the intermediate category, and you can imagine what they are. They're low mismatch, but happen to get basiliximab, which is the weaker agent, or they're highly mismatched, but then they got ATG. And then you have the highest risk, that patients who are highly mismatched and they didn't get ATG, they got a weaker one just because we made a wrong choice. And their risk of rejection is close to 20%. So this is all retrospective study, but can we actually actualize this? You know, we talk about precision medicine. This is precision medicine. We're using diagnostic information to guide therapy, but how can we actually do this? What would the workflow look like in the lab? So to define high or low mismatch between donor and patient, we need to sequence patient and donor. We need to take DNA from donor and the patient, put it into a sequencer, and what you see here is what we call MySeq sequencer. It's a large desktop kind of a machine, and it's very powerful. We can sequence a lot of data, but the downside of that is it takes a week to do the sequencing and for people to get the results. Once we get the results, we get this resolution that we call high resolution. We put it into a algorithm to compare donor and patient amino acid in a 3D structure to define whether they're high or low mismatch. That's how it's been done. So as you can imagine then, the problem, the limitation in the workflow is the sequencing part. Because if you work in the organ donation site, how many hours do you give the lab or the clinician to allocate? 5, 6 hours, right? Between the time when we type the donor, we have about 5, 6 hours, then to allocate the organs to bring the patients in. So it's not going to work if we are relying on this benchtop sequencer, which takes a week. So I'm going to do a Steve Jobs here because we're all about technology, and things kind of changed in a few years ago when we were able to do sequencing on this machine called nanopore. And it's very striking because the first thing is that it's very small, so it fits nicely into a pocket, and I can carry this and sequence people whenever I want to. But the other unique thing is that it's very fast. It doesn't take a week to sequence. It only takes about an hour or less. And so now you can imagine for deceased donors, you get a blood to us, we isolate the DNA, we open this up, we dot the DNA in, and in real time, in about an hour, we get the results back on the donor. Why do we want that? We want that because then that allows the opportunity to now risk stratify the donor and find out how well matched they are to our patient. And then the clinician at the bedside will have that information, and then they can give the immunosuppression that's appropriate. So Dr. Sherwood, who is a director in our lab, has been driving the development of this nanopore. And I think in a few months, we'll be the first one in the world to be able to do this in real time. This is not a retrospective study. This is actually just doing it. And as you see now, it's called nanopore because it consists of a lot of pores inside the flow cell. And as the DNA gets dragged through those pores, it causes a disruption in the ionic current. And based on the current, it's measured, it can call the base type. We have the 4 different nucleotides. You can identify what nucleotide it is. And that's called real-time sequencing. What you see on the right there is the difference in the sequencing time between nanopore and currently what we use for MySeq. That time is drastically reduced into something that's feasible for deceased donor allocation. And so here's the workflow for extraction, setting up in the lab, amplifying, all the way to reporting. We can get this done in a few hours' time now. So this is where we think we can go in the future. Up until now, we're in a constant state of are they going to reject? Are they going to get infection? It's a one-size-fits-all approach to immunosuppression, to allocation. But the future, we think we can increase that safety zone because we can now actually find a donor that's a better match for the patient on the wait list. If they're well matched, it's like those twin transplants that you see in the beginning of time, that they don't need so much immunosuppression because they're not going to reject. And because of that, they're not going to get a toxicities as well too. So the other question, this is about organ allocation management. The other problem that we have is once we put the organ in, and if you, again, work in post-transplant, immunosuppression gets adjusted all the time. Patients have diarrhea, they have a tremor, their immunosuppression gets cut back. And sometimes they want to take those medications. Patients want to do that, but they can't because they don't feel good. And whenever I have to cut someone's immunosuppression, the first question that the patients ask me is, am I going to have rejection? And the bottom line is, I cannot say with confidence. And it's amazing that after 50 years of doing transplant, we still cannot measure the immune response. Dr. Keown likes to give the example, which I'll steal here, is that it's like we have to treat someone's blood pressure without a blood pressure cuff. We can only estimate what's going to happen to them when we cut immunosuppression. So can we monitor patients better? And that's been a holy grail in transplant as well too. So what can we do? What's the innovation? So I'm going to tell you a story. Danny is my wife. She visited me. This is back in 2014. I was training in Los Angeles. And she was pregnant with our first child. And, first time father, I was really excited to learn the sex of our baby. And back in the days, I did not want to wait for the ultrasound to find out. And because I was working in a sequencing facility, I said, why don't we just take your blood and let's try to work this out. Because at the UCLA campus, they had this very intelligent person who started prenatal testing this entire field. And you guys will know this is commonplace now, is that when a woman is pregnant, there's fetal cells that get released into the mother's circulation, and you can actually detect it. So that's what we did. We took Danny's blood, we isolate the DNA from her, we sequenced it, and because of the chromosome difference and the genetic difference between the mother and the child, because half the child's DNA comes from me, they're different from her, we can tease out what's the sex of the baby. So we found out very early on that we're going to have a boy, Jake. The time is that this assay was very expensive to do. It was going to cost us something like $2,000 to do. And it wasn't approved for MSP as it is now here. But then things evolved. 4 years later, we had our second child. And this time, we didn't have to do that anymore. We can just pay for it because sequencing became cheaper. It became possible to do that just by paying. You still have to pay a hefty price, but the cost has come down dramatically. But then at the time in 2014, I wrote a paper. I said, well, this technology is fascinating, but it could be applied to transplantation. Is that when you have an organ transplant, the organ's DNA is different from the patient. It's almost like the patient's carrying the fetus as well too. And maybe we can measure that. And sure enough, somebody applied the idea and actually use that, make it an assay. And the idea here is that if there's injury to the kidney is going to release DNA, and you can measure that. So if you quantify the DNA between the donor and the patient, and you see the donor fraction goes up, that's indicative of allograft injury. And so that's now been shown to be very much true. What you see on the right-hand side first is that if you look at patients with rejection versus no rejection, if you rely on creatinine, which is what we do today, that's the standard of care, there is no difference between them. And we know this very well. While in the acute phase, early rejection, creatinine is pretty good for detecting rejection. But once you're out of 6 months to a year, by the time creatinine goes up, rejection has taken place for a long time. And by the time you want to treat it then, it's too late. Therapies don't work. And that is the problem, is that relying on clinical standard of care biomarkers, creatinine, protein, they're late findings. But what you see on the left-hand side, though, is that the cell-free DNA fraction is much higher amongst rejecters versus non-rejecters. And so that could be a way to allow us to monitor the graft health of the patient. But all these, where do we stand today? You see that publication is fairly recent, is that these are, again, retrospective studies. And no one has been able to show yet, if we apply this assay clinically, are we actually going to change the outcomes for patients? Because this assay is expensive. It's $3,000 US per test. This is my last slide before I hand over to Dr. Keown. So John Gill and I, we came together with a proposal for a multi-center trial. Again, we want to find solutions. We want to move the needle on transplantation. We said that we need to have a prospective trial to assess whether this assay, if we apply it, is going to lead to a meaningful difference in the graft function of patients. So this is under review at CIHR currently. We should hear back in about a month. It's an ambitious trial. It's going to bring together Canada, all the sites. We have 11 Canadian sites. We're looking to recruit 1,600 patients. It's a 5-year trial. And the idea here is that it's a randomization trial. So patients will come in after transplant. They'll get randomized either into standard of care, in which case nothing happens to them. They just get creatinine measurements. That's what we do now. But half of them will get cell-free DNA at regular time points after transplant in the first year. The idea is that some of these patients, they will have elevation cell-free DNA. It will lead to earlier diagnosis and earlier treatment of rejection. And in the long term, that's going to preserve their kidney function. So rather than waiting until the end when creatinine rises and rejection has been going on for a long time, we now perhaps can shift that time frame up and detect rejection when it's subclinical before creatinine rises and treat it earlier. If there's one thing we know about rejection is that it's much easier to treat when you detect it early. When it's late, there's not much we can do about it. So I hope that shows you that we're taking real steps towards implementation of technologies that I think have a chance to move the needle on the outcomes. I will pass it over to Dr. Keown, who will take us to tolerance.
Thank you very much, James. That was wonderful. Dr. Lan has laid out for you the premises of precision medicine, the technologies, the tools, the strategies that we can begin to use now to change transplantation. And although he didn't say really fundamentally, Vancouver is at the leading edge of this. James's lab is probably the premier lab in the world now in terms of introducing these technologies, driving them forward and applying them. So the lab and James and everybody involved deserves great credit here. So my task now is to ask, having these tools, how do we actually go forward? And we'd like to present to you conjointly 2 programs that we think will be truly revolutionary. They will be world-first programs. They are being developed in BC. They are being implemented in BC. They will then be run out across Canada, and we think they will be world-leading. And the first is for epitope-based matching, and the second is for the induction of tolerance post-transplantation. And one builds upon the other using the technologies that Dr. Lan has described. So the problem that you see with historical transplantation is that immunosuppression is unreliable. If we can maintain full immunosuppression, we rarely get rejection. But the problem is we get lots of toxicity. And as people become toxic, we have to reduce the dose, and that allows rejection to break free. If we could actually have non-toxic drugs, or better, no drugs, then that would be really useful. So what we want to do is to draw upon these expertise and think about how do we arrive at that. So the first step is to see if we can reduce the immunogenicity of the kidney. As you saw, when we put the kidney in, the recipient immune response, my response if I get a kidney or a heart, recognizes the foreign HLA antigens, attacks the organ, and destroys it very quickly. So first is to minimize, to hide, if you like, the organ, to make it invisible. The second is to adjust the immune system so that it recognizes the new organ as ourselves. The third is to use some of these tools to maintain quiescence long-term. And then the fourth, which is really important, and Genome Canada requires this of us, is to measure outcomes. Not just does the kidney survive or not, but how do people feel about it? What's the quality of life? What's the economic? And what are the societal benefits or otherwise, of what we do. So we'll take you through some of these. So let's think now about reducing the immunogenicity. The reason that we reject the kidney, as James showed, is that we recognize the foreign antigens. If we could match, if we can match genetically, then that difference disappears and we accept the kidney. So if I get a kidney from one of my recipients or from one of my relatives who is HLA identical to me, I do very well. I might keep the kidney for up to 50 years. I might have no rejection. I only need very minimal immunosuppression. If I get it from somebody who's vastly different, then I'll reject it aggressively. So we would like to genetically match, but on the left-hand side, the green bars, you see the number of forms of the HLA genes. These are profoundly what we call polymorphic. There are over 36,000 different forms of the gene. So there's no way we can match. Even with a big population, we can't match. In the middle are the epitopes that we showed a moment ago, that Dr. Land showed you. Now, instead of 36,000, we reduce it to about 100, between 50 and 150 epitopes. So matching becomes much, much more possible. And within those 50 to 150, if we look at the far side, we can ask, of the people who have received a kidney and who have had rejection and formed antibodies, what are the targets they form them against? And there's a very small number. This is also some work that Jenny has done. And it shows we may have less than 50 important targets, and they occur only in two key genes. One we call DQ, and one we call DR. So out of all of the genes, only two are important, and in those, only a few of these molecular targets are important. So now we have a great potential. Instead of having to match people for thousands of genes, we can match for just a few epitopes. So let's think about it. In the data that Dr. Land showed you with the retrospective review, where the well-matched patients did well and the poorly matched patients did poorly, only 14% of those 1,000 patients were well matched just by chance alone. So these were people who got their organ. It wasn't specifically allocated on the basis of match. Only 14% received a well-matched organ. Well, that's great for the 14%, but it's not great for the other 86%. What we want to do is see if we can increase that from 14% to nearly 100%. And the answer is yes, we can. So here we're able to map out, if we took those 1,000 patients and their donors, and we reallocated the donors to them on the basis of matching, what would be the probability that we could give each recipient a well-matched, epitope-matched organ? And the answer is the very top line. So over 90% of those patients could have expected to receive a well or perfectly matched epitope-based organ if we had reallocated on the basis of epitope matching. So that's really profound. It says, if we start from now for the next 3 or 4 years, which will be 1,000 patients, and if we reallocated the organs on the basis of epitope matching, we should be able to have a well-matched graft in over 900 of those 1,000 patients. That's truly stupendous. And you saw the outcomes that we see retrospectively. We only have a few percent rejection, 5% rejection. And we're beginning to think that that rejection may also be a milder form of rejection. We have begun to see the really aggressive kinds of antibody-mediated rejection disappear. I think the last data that Dr. Land showed me was 2 cases out of 1,000 grafts, very small numbers. So now we're approaching the realm of possibility where we can see something great. But we need to be cautious, because when we allocate organs on the basis of genetics, we worry that we may leave some people out. We know that, for example, for ABO-matched transplantation, there are people who are difficult to transplant. For example, the Bs and ABs are sometimes more difficult, and they travel with ethnic groups. So we want to make sure that in advantaging some, we don't disadvantage others. So we can begin to calculate that. And the graph on the right shows that. The vertical axis shows the difficulty to match. And the x-axis along the bottom is those 1,000 patients just aligned one after another. So if we start at this side, the cases in green, the little green dots, are the ones that are easiest to match. They're lowest on the scale. They can match with the first donor that comes out of the chute. Then as we sort of get a flat level over a period of time, but as we get to the right side, you'll see some red dots. And those red dots are the people who are going to be harder to match. So if we're thinking now about setting a system up, people will come along, instead of taking the next donor, the next recipient on the list to get a kidney, we actually select the best one. It may not be Mr. Brown, who is the next on the list. It may be Mrs. Jones, who's 50 down the list, but we're doing it to give a better match. But we don't want those people who are the red people to wait for 2 or 3 or 10 years because they can't get a good match. But the great news is now, using exactly the sequencing techniques that you saw a minute ago, when that person is first referred to us for transplantation, before they even go on the list, we can actually type them and we can predict right away. You will be a green dot, really easy to match. You will be average, or you will be a red dot, difficult to match. And now we can think about different strategies. If you're up to the red dots, you just go on the waiting list and we try to give you the very best epitope match that will come along. If you're a red dot, we have a couple of options. We actually bypass the list entirely and you get the next kidney that comes along, because it's only 10% of patients that are difficult. Or we put you on the list, but we relax the criteria. We don't have to have a perfect match. We can have a good epitope match, and they may be able to accept a good epitope match. Or we may put you on the list and you may elect to wait for a year for a really good match. And if you don't get it within that time, then you get the next one. So we have a series of strategies that we need to consider from medical and societal perspectives so that we have justice in the allocation system. So you heard about the rapid sequencing, and this is transformational. James showed you the sequencer that we use, the sort of thing that Steve Jobs would have done. I'll actually pull up because I'll be Steve Jobs as well. And we think of a phone. Phone is transformational, not because we can make phone calls on it, because nobody makes phone calls today, but we can text, we can look things. It's transformed what we do. And this new approach to sequencing transforms what we do. So now we can measure cell-free DNA. We can measure the sequencing of the receptors on the T cell, which are the first thing that expand after a transplant. We can begin to get very, very early signals that rejection might be occurring, and we can intervene. So this is truly transformational technology. So we want to implement it. How are we going to do that? So we're first implementing it in BC. And the system is here, set up, and within a couple of months will be operational in BC. And as Dr. Land said, that's going to be the first laboratory worldwide that's doing this routinely clinically. But we need to validate it because we need to know that the system can work elsewhere as well. So within the Genome Canada program, we've picked validation sites. And you can see here, one of our validation sites is in McGill. And they have already begun to start their validation process. It's going very well. It shows they can do as well as we can do once we set it up. And then we're going to apply it to all of the HLA laboratories in Canada. And we're anticipating that within the next 12 months, all of these will be implemented in each of the laboratories. This will make Canada the very first country in the world to be using this new technology and to use it in a standard fashion. And when we present this at international meetings, people are just amazed that we can do this, but we can do it because Canada works very well as a team. So now, assuming we have this all set up across the country, we can begin to think of developing and extending epitope matching from BC to Canada as a whole. So what are the rules we'd use now for allocating the organs? Well, interesting that I don't think they'll be very different from the ones we use today. So medical urgency will be number one, of course. Highly sensitized patients, yes, that's a national program. Pediatric patients, yes, of course, although they will also be epitope matched. There's a program now in place to do that for them. Then multi-organ transplants, yes. and then eplet matching. So what it will mean is instead of having a long string like a queue waiting for Starbucks with the next one getting the next organ, we will have the waiting list, but we will select according to the best epitope match. So we need now to do 5 things to implement this program. First is we need to communicate with our patients and our teams. We need to explain to them what we'd like to do. We need to explain to them why we're going to do it and why we think it will really improve things for them. Then number 2, we need to confirm the allocation schedule that we will use. Will it be this or a version of this? Probably doesn't matter too much, but we need to confirm it and we all need to agree that this is what we're going to do. Then we need to sequence the patients so that we can rapidly allocate the donor to each organ. We think we're there, we can do this in a couple of hours. The time is getting shorter. It will probably even come down to an hour or 2 very soon. So that's not a problem. Then we need to transplant the organ and follow them to make sure they're doing well, make sure that there are no breakthroughs in rejection. And finally, using this information, we need to begin to use the tools that you saw Dr. Land describe to see how we can safely reduce immunosuppression. Immunosuppression has moved from being a friend years ago to being a foe at the moment. It's necessary, but we want to get the dosing down. But we want to do that carefully and appropriately. So now we're going to tell you about another revolution. You're hearing about many true revolutions of precision medicine today, but the next one is in trial design. So everybody knows clinical trials, conventional trials. You have a new drug or a new test that goes in your experimental arm, and then you have a control arm. You have several hundred patients in each arm, and then you compare them at the end of 2 years. That's the traditional trials. But COVID changed many things, and it changed clinical trial design forever. So it's collapsed trials in time, and it's revolutionized the way we do them. Now, if we think about the frequency of diseases, we're talking about a rare disease here. We do 250, say, deceased donor, 300 maybe deceased donor transplants in BC per year. But that's not like cardiology where they have 10,000. These are very small numbers, very precious patients. We want to use them appropriately. So the new trial design from COVID uses synthetic controls. It takes controls from the past and it matches them with the new patients. So now we can look at 200 new patients going into this trial and comparing them, let's say 3-to-1 or 4-to-1 with carefully matched patients from our data sets over the last 2, 3, or 4 years. And that now serves as a very rigorous control to let us know how we're doing. But also there's another change at the outcome end. In the past, we would have, say, followed these patients for 2 years, then compared A with B. We don't do that anymore. We set in place mathematical lines. So you can see on the far side, there are 2 lines, one sloping down for success, one sloping up for failure. So now we're moving forward in real time. And if we cross one of those lines, we know we're successful or unsuccessful. So very quickly, we can now take all of the patients that we're going to transplant, we can compare them against our historical synthetic controls, and we can look in real time to the outcomes. This means we can test difficult questions much more quickly with much more success and rigor than we ever could before. So we have transformational change in technology, and we have transformational change in outcome measurement. So if we're successful, the plan is that CBS will adopt this new program. We have another proposal into Genome Canada at the moment. CBS will adopt this new program and will implement it as a national program, just like, for example, our highly sensitized program. So any center across Canada can quickly look at the epitope allocation, allocate their organ to the next donor, and most of these can be done within province. The ability to match is within province. We only need to share for maybe some of those more difficult patients. So let me turn to the second one, which I think is the thing that now I see as the Holy Grail. For a long time, the induction of tolerance has been something we've really tried to achieve with very limited success. The only few successful anecdotal patients have been patients who were highly matched living donor recipient pairs. So, a few patients, even the big centers have done 10 of these, which means it's not applicable for everyday transplantation, but we think we can transform that. Because if epitope matching is successful, it means we change all of our recipient donor combinations into the equivalent of highly matched living donor recipient combinations. Now we reduce the immunogenicity, we change radically the risk of rejection. This means now with a little extra push, we can maybe induce tolerance. So tolerance means that we have long-term survival of the kidney and are able to remove all or almost all immune suppression. So the question is, how do we do that? We do it by chimerism. So at the time of transplantation, we know from animal and human studies that if we want long-term survival, we need some circulating cells from the donor, preferably stem cells from the donor that keep circulating so our immune system sees them, sees that they're not dangerous, comes to live with them and accept them. It's like somebody coming home one night and you find a guy in your apartment and you're ready to throw him out, but he's watching hockey and he's brought beer and you think, well, we'll throw him tomorrow. And then he brings beer every night and eventually you sort of live happily together. That's what we want to see with tolerance. We know the kidney or organ will always be foreign, but if we can get our immune system to accept it and live harmoniously with it, we've achieved what we want. There are many ways we can do this using radiotherapy, immunotherapy, and cellular therapy, but the principle for all of them is the same. That at the time of transplantation, we take stem cells from the donor, we grow them up, we prepare them in a special way, and 10 days after the transplant or so, we administer those stem cells and they begin to grow and they form chimerism. And then over the next period of time, 6 months to 1 year, we begin to remove immune suppression under the careful monitor of the precision medicine tools that Dr. Land described. We think we can enhance that also by administering regulatory cells. There are many, many different types of regulatory cells now being tested. But the combination we think will work is stem cells from the donor and regulatory cells from self, which will begin to replace immune suppression. Let me just move past that one. So now if we think back along the process, the first step is the epitope matching to reduce the immunogenicity of the graft and other tools we're planning to use. The second is the induction of mixed chimerism with stem cells from the donor. And the third, to maintain quiescence long time as we begin to remove immunosuppression, is the use of expanded self or autologous regulatory cells. So that sounds good so far, but the immune system is a very crafty system. It's built to defend us. That's its goal. It's like a robot. It has no other intuition. It just wants to seek out problems and eradicate them. And there's not just transplantation problems, but there are infectious problems and there are tumor problems, both of which occur after transplantation. And the problem with the immune response is it's like Smaug in Lord of the Rings. You all know Smaug, the big dragon, and it wakes up and then it destroys everything around it. And that's what the immune system does. Once we wake it up, it destroys everything around it. So we want to keep Smaug asleep. So we want to monitor really carefully. We're using exactly the same precision medicine tools you saw to measure the transcriptome of the patient, to measure the cells which would recognize the foreign donor, to see that everything is quiet and quiescent and Smaug is still asleep. And then we're going to back off the immunosuppression to make sure that everything is safe. But we will need to monitor patients in a way which is much more sophisticated than today. So let's think about Mrs. Jones, who lives in Prince George. She comes down here, she's transplanted, she's out of hospital in 5 days, she's followed down here for 3 or 4 weeks, she's doing really well, creatinine's 110, she goes home. And then she's seen every 3 months. But then a year and a half from now, something happens. And of course, it's just after her last visit, so she's not due to go back to her nephrologist there for 3 months. And during that 3 months, the immune system becomes destabilized. So by the time she sees her nephrologist there, her creatinine is 250, her graft is being eaten away. And as Dr. Land said, once the immune response becomes activated, it's very hard to put it back in the box. Once the genie gets out of the bottle, that's often the end of the road. So we're going to have to think about changing the way we monitor patients. We're going to have to adopt virtual programs and platforms so that we can monitor them all the time, which is why the new technologies become so important, because these are transportable technologies. Not only can they be used to sequence anybody at any time here, but they can be used to sequence people around the province. So now we can follow patients using these tools on a weekly basis if we want, more likely a monthly basis. We can detect when it's likely that the immune response will become destabilized, and then we can have blood sent from them here, immediately tested within a day. We can give the same day readout, so the physician in Prince George can respond. So all of these, I think, will come together in a way we've never known before. They will be truly transformational. And 5 years or 10 years from now, at the very most, I hope we'll be looking at a program where we can transplant patients with the expectation they will keep the kidney or the heart or the liver for the rest of their life. So before I close, let me offer an invitation and a request. You can see where we'd like to go. The team at BCTS, Ed and Derek and all the rest have been wonderful in supporting this. What we would like to do is now make this a provincial initiative. We would like to invite all of your help, because first we have to communicate with the patients. We want to develop the tools so that they know clearly where we're going, what we're planning. We want them to be part of the process, because really we're doing this for and with them. Then we need to set up our plans to actually organize the scale, the allocation schedule to say how we will do it, make sure everybody agrees with it, and then we want to set up the process for transplantation and follow-up. So we look forward very much to working with you over the next couple of years. We invite your input. We're here. We'd love to hear from you, and we will reach out and try and integrate with each of the separate teams as we plan this next step forward. So on behalf of Dr. Lan and myself and all of the team, thanks very much.
Thank you very much, James and Paul, and congratulations to you and your teams. This is really amazing work. I'm sure we have some questions. I just had one thing I wanted to ask or try to understand, and it's the idea of, with the matching, that generally using this form of matching, that most kidneys would stay in province, but if you start expanding it out to other organs where there's just fewer opportunities, if this is applicable, would you see a lot more sharing nationally in order to do that?
James has the microphone.
Yeah, I think when it comes to organ allocation, it's a fundamental shift, and there's different layers of barriers we have to overcome. So for kidney, we plan to start by doing this in BC first, but then to expand across the whole country. And as Dr. Keown said, that's because we want every patient on the wait list to find the best matched organ for them. And sometimes with a donor pool of less than 200 donors a year, that's just not going to be viable. But then when you have to go across the jurisdiction, we have to remember that Canada doesn't really have a national allocation system, unlike some other countries. Every province, they allocate according to their own set of rules as well too. And so to get national buy-in, it's not something that we can do from day one. So we hope to lead the way by doing this in BC first. And then there are many other provinces that are looking to see how we're going to do this and what our outcomes will be. But I think they're ready to jump on as soon as they have confirmation that one province is able to do it. And that's why, as Dr. Keown said in the slide, we're very keen in parallel to set up this assay across the country as well too, knowing that they might not be there on day one, but in a few years, they'll be joining us as well. For the extra-renal organs, it's more complicated because they don't have the luxury of time to wait necessarily for a better match organ. If they're waiting for liver, for heart, for lungs, it's not going to be the same consideration. And so, and the risk of rejection is also different. For instance, for liver, rejection is less of an issue for them compared to kidneys. So they will have to take this into consideration. But I know they're very interested before they reallocate organ in a different way to know how can they do the same thing to take the mismatch data that we show to guide immunosuppression regimen to minimize immunosuppression. That is very doable.
Thanks. We have a question. Will epitope matching only be used for standard criteria donors, or can it be used for really essentially everybody? The principle is very simple. If we can reduce the immunogenicity of the organ, it applies to anybody. But what we may end up doing is stratifying within groups. We haven't come to that yet, which is why it's really important to have this societal discussion on how do we structure our allocation criteria. And it may be we start with a simple one, and then after 6 months, we review the data, and then we change it. So it's not a major hurdle at first, but I think these are the kinds of questions we need to build into the process.
So as an organ donation coordinator, when I get the selection report for the kidneys is quite long. Would that testing have been done on that whole selection report, or when I offer it to the renal program and they say, oh, we'll take these, put these names on flow cross match?
That's a very good question. So what will happen is everybody who's listed on the wait list already have their genotypes characterized. So all you're waiting for is what's the donor's typing. And when we do the nanopore sequencer, we can rapidly get a donor typing. Then right away, we have an algorithm to calculate the degree of mismatch between the donor and everybody on the wait list. So the selection report will have to create a column where we will say, beside Mr. Jones, their name beside it, their age and so on. But the last column will be mismatch with the donor. Then it's up to the clinician then whom they pick to give the organ to. Right now, as you know, it's going by wait time. Whoever is waited the longest, they will get a first pick. But what we're discussing here is that might not be the way to go forward. Rather than go strictly by wait time, perhaps it makes more sense to give some patients the option that they get a better match organ.
Any other questions here?
Sean.
Pointing somebody. Oh, sorry. Oh, hi.
Hi, great. Well, again, thank you, Dr. Keown and Dr. Land, for your leadership in putting BC's technology and pushing through nationally and internationally. Just for your last point, Paul, and asking for support. Certainly, yeah, we're happy to support. When, in terms of timeline, when for our rest of the system, do we expect to sort of hear in terms of how we can help with this really important initiative? Yeah, just sort of rough timelines for BC and then elsewhere. Thank you.
With pleasure. Thank you. So I should explain about this Genome Canada grant. It's the follow-on Genome Canada grant, and it's a fairly sizable grant, and it has what they call receptors. Receptors are organizations within the healthcare, within healthcare that take the lead. And ERIC and BCT are the first receptor, and CBS is the second national receptor. So ERIC and team, thank you very much. This is so important to have you there. Now, we'll hear about the grant probably in January, but we've decided that we're so advanced, we literally are more advanced than any other team in the world. There's no point in waiting. What we should do is move ahead. So Eric, maybe we can come back to you and we can say, if you're in agreement, and if the BCT in general and the transplant teams are in agreement, we should move ahead now. There is nothing to stop us moving ahead, beginning to plan the information that will go to the patients, beginning to discuss the allocation schemes that we would use, beginning to discuss the process and the follow-up, so that if we can do this quickly, by the time we receive notification of the award in January, hopefully it will be positive, then we will have everything in place to move ahead. And even if for some reason we're not successful on this round of the genome competition, we will have done everything to move ahead. We have the technology in place. we will have laid the plans for moving forward, and we can still introduce the world's first epitope matching program. So if this is okay with you and the team, Eric, that's what we'd like to propose.
Yep, let's do it.
Good.
If there's no other questions, thank you so much for coming and sharing it with us
Very
today.
well.
Great work.
Thanks very much.